Well, good evening, everyone, and thanks to all of you for joining us this evening for another Restless event with our partners, My Menopause Centre. This evening, we are looking at menopause and neurodiversity. So before I hand over to Helen, who'll chair this evening's event, I want to remind you all to please post your questions and thoughts in the chat function at the bottom of your screens. And feel free to post throughout the presentation, and there'll be time for questions at the end as well. The event will run for 1 hour and it is being recorded and will be emailed to everybody who registered for it. So I'll hand over to Helen now, who's our chair this evening. Helen O'Moyle is the co-founder of My Menopause Centre. Over to you, Helen.
Aideen, thanks very much for that introduction, and good evening, everyone. Thank you so much for joining us for this really important conversation. Now, as you'll have seen from the invitation to this event, the impact of the menopause transition on neurodivergent people, in particular those with ADHD, that is attention deficit hyperactivity disorder, or autism, it really is a hot topic right now. ADHD affects 3 to 4% of both men and women. Autism, 1 in 100. Some people are diagnosed in childhood, others as adults. Either way, going through the menopause with ADHD or autism can be a perfect storm. Symptoms can overlap and pre-existing symptoms may worsen, making for a very challenging time. But with the right support, it need not be this way. And hopefully that's what you'll take from this evening's webinar. And that's why I'm really delighted to have with us this evening my brilliant co-founder, menopause guru, Dr. Clare Spencer, and Dr. Rachel Moseley, principal academic in psychology at Bournemouth University. Dr. Rachel herself, as she will share, is autistic, and she was diagnosed in adulthood. Now, before we start, I'll call out a few housekeeping points. Please do put your questions into the chat. And as I'm sure you'll appreciate, though, Dr. Clare and Dr. Rachel won't be able to answer individual specific medical queries, but they can, of course, respond on a broader level. Now, Dr. Clare, we'll kick off with a question to you. It would be super if we could start with a recap of what's happening in our bodies as we transition through the menopause, and then in particular, why our mood, our cognitive function are impacted in this transition.
Yes, thanks, Helen, and good evening, everybody. So basically, menopause transition is a time of massive hormonal turbulence and change. And ultimately, what's happening is our ovaries stop rhythmically producing estrogen. So at the start of the menopause transition, the estrogen is fluctuating wildly and erratically, and the troughs of the ups and downs will be deeper. And then what happens as you go through that perimenopause, which is the start of the menopause transition, the estrogen level gradually falls. And then in the point of time of the menopause is when you can look back and say, I haven't had a period for a year. And then the estrogen is low and it stays low forevermore for the rest of your life. And it's the fluctuation of estrogen and the drop of estrogen together that can really impact on symptoms. It's not just the drop. There's some quite neat studies showing that actually women who have more fluctuation often have worse psychological symptoms, so low moods, depression, anxiety, etc. So I'm sure in terms of symptoms, everybody's heard of hot flushes and night sweats, and there are a plethora of other physical symptoms like bladder frequency and sensitivity, generalized aches and pains, changes of periods, changes of skin sensation, so sensory changes. I could go on. But I think particularly tonight, it's really important to know that with that loss of estrogen also, there's a real neurological change. It's a neurological transition point because we know that the structure and function of our brain changes, that drop in estrogen changes many of the chemicals or neurotransmitters or neurochemicals, the brain messages in our brain that keep our mood up and keep our anxiety low. Those chemicals really impact on how rewarded we feel, for example. So we know that with the drop of estrogen, serotonin is lower, dopamine is lower, and that's really relevant in what we're talking about this evening: noradrenaline, GABA, and cortisol, the hormone related to stress, can increase. So in summary, the take-home message is hormone change equals psychological symptoms, because the hormones impact on the chemicals in our brain that really control how we think, feel, behave, and that can therefore make this a really challenging time, particularly if you happen to be suffering with if you are a neurodivergent woman, I would say. Yeah.
And Claire, before I come to Dr. Rachel to look more specifically at ADHD and autism, just in terms of what's the typical age for the onset of the menopause transition, the perimenopause, and roughly how long do symptoms typically last?
Yes, no, absolutely. So the average age in the UK is 51, and that's the average age of the menopause. So that's 12 months of no periods. But it's normal between the age of 45 and 55, normal as in most frequently people go through menopause 45 to 55. An early menopause is about 5% of women, and that's from the age of 40 to 45. And then a premature menopause is around 1% of women, and that's a menopause under the age of 40. But if we think that the perimenopause, so the start of our hormonal change and turbulence, the perimenopause can start around 5 years before the menopause itself. You can see how symptoms start to build up really commonly early 40s, mid 40s, and then late 40s, obviously, but can be younger. So often people will say that, you know, they've been dismissed, they've been told that their symptoms can't be menopause related, but actually they can occur at any age. It's just more common in that sort of 45 to 55 bracket.
Thank you, Claire. And I've just popped a link to an article that Claire wrote that's available for free on our website that explains all the stages of the menopause transition, duration, and so on. So it's a great article if you've got time to check it out. And I see we're getting some really great questions in the chat. We've got to line them and we will come to them. We'll either weave them in or we'll come to them at the end. So keep them coming, and thank you very much for those. So Dr. Rachel, it's really great to have you here this evening. I know you and Dr. Clare have collaborated together before, and you really bring a fantastic perspective and understanding to this topic for us. But before we get into ADHD and autism in the menopause, we thought it would be worth stepping back just to spend a moment on neurodiversity and to help us all understand what the term means, and also why it's important for us to reframe how we think about neurological differences.
Well, first off, thank you so much for having me here. It's a real pleasure. So, neurodiversity, if I was to give you a definition, I would borrow heavily from the concept of biodiversity. So basically, this means the Earth supports different life forms, and different animals do better in different environments. They have different needs, they have different behaviours. Neurodiversity means just the same thing with brains. So there are different types of brains in the world, and they do better in certain learning environments. They have particular strengths, they have particular challenges. And so this approach to thinking about neurological differences like ADHD and autism is really important, because it recognizes that neurodivergent people bring all kinds of strengths to society. And it aspires for a lot more for us. So rather than thinking of us as broken or disordered, in which case we're always going to be sort of struggling and we're always going to be sort of deficit based, if we think of these things as differences, we can see what they bring to society, and we can more easily recognize a world where neurodivergent people don't have to be suffering, so we can thrive.
I've not heard that explanation before, but it's absolutely gorgeous, Dr. Rachel, because it just calls out the strength that comes from having a diverse, so the strength that comes from biodiversity and why it's so good for the planet. And when you frame it in that way, it really shows the value of having an inclusive way of looking at things and not expecting everybody to fit a predefined form or a way of living or a way of being. So really appreciate you sharing that with us and helping us to think about this differently. So if we turn our attention then to attention deficit hyperactivity disorder, ADHD, it would be super if you could just talk us through how does it manifest in daily life and the different types of ADHD that there are.
Sure. I want to say first off, ADHD is a terrible name. It's very poorly named, both in terms of the deficit disorder aspect, but also it's not a very good description of what ADHD actually is. So let me explain that. If we look at the kind of formal definition of ADHD and the kind of criteria, then there are two. One of those is inattention. The other one is hyperactivity and impulsivity. And you can be diagnosed as inattentive subtype ADHD, hyperactive impulsive subtype, or even the combined type. So you've got both of those features. Tricky thing is, when we're talking about what is formally called inattentiveness, it's not a very good description. So people with ADHD, or ADHDers as I like to say, they don't have a deficit or a deficiency of attention. Rather, what's going on is that they struggle to control their attention. So this means having a brain that is forgetful at times, that you cannot make it, you can't pin down your attention to anything. So even when you know you have to listen to this, you have to complete this, you have to do this task, you cannot, literally cannot force your brain to do it. It's painful, it might make you sick, it's distressing, you cannot pin your brain down. But then on the other hand, you'll have times where you've got attention in abundance, where you fall into a black hole and you're super productive at this task, but the rest of the world around you disappears and you don't notice that you're hungry or that you need the toilet or that other people are around. So it's difficulty controlling your attention. You can't go into this hyper focus at will or turn it off. You can't focus when you want to. So it's that controlling attention, which is so tricky for people. The hyperactivity and impulsivity aspect means that you might really struggle to control your impulses. So you might feel, really restless, fidgety, and it's painful or unpleasant to kind of inhibit that. You might find it hard to not speak what's in your head. But of course, a lot of ADHDers spend a lot of time masking these features. So hiding the fact that they keep drifting away and they miss things, hiding, trying to suppress these impulses. And it's worth mentioning a few other features of ADHD which aren't in the diagnostic criteria, but which are really, really important to the experience. So things like sensory sensitivities, things like emotion differences. So people having huge emotions, masses of empathy for other people, and emotions that are really overwhelming. And so they might experience things like rejection sensitive dysphoria, where, they are people with ADHD are very often invalidated and victimized, and hence they become very, very sensitive to, perceiving that, and it's a really difficult thing to cope with.
It's fascinating the range of ways that you described in terms of how it manifests. And one of the things that you touched on and that you mentioned was diagnosis. How is ADHD typically diagnosed in children and adults? And are there differences in the symptoms presented by females versus males?
Yeah. So, tricky thing about ADHD and autism is that there are no biological tests to measure or assess either of them. There's no brain scans, no blood tests. It's all done on behavior. And the tricky thing when it comes to people assigned female at birth is that very often they are quite good at masking, at hiding their difficulties and their differences. So what we tend to see in young ADHDers and also young autistic people who are assigned female at birth is we see a more normalized social presentation. So more normal eye contact, more normal use of gesture. They often mimic the social behaviour of other young people. So you're more likely to see this in young people assigned female at birth and also adults. So basically what this adds up to is that autism and ADHD tend to be diagnosed in females who have more obvious differences or difficulties. These need to be a lot more obvious. There need to be co-occurring things in the picture in order for people assigned female at birth to be picked up.
Thank you. Now we are in a moment, we're going to come to the things that Clare alluded to happen in menopause and why they can trigger, you know, a more challenging environment or situation for women going through the menopause. But also we'll touch on something that we've discussed. Is this a point in time where women, as they go through menopause, realize then that they have ADHD in particular? But let's look at autism first. Let's turn our attention to autism first. And again, I've just noticed we've got lots of really great questions coming through in the chat. So I wonder, Clare, as Rachel is speaking, if you could have a look through them, and Clare, when we come to Rachel, if you could have a look through them, and then we can think about the best way to address them so that we ensure we get to everybody's questions before we finish the webinar. And one of the things we will touch on as well is the challenges that symptoms can present in the workplace or in relationships, and tips and strategies to help manage these. But before that, Dr. Rachel, it would be great if you could help us to understand what autism is and how it presents across the spectrum.
Sure. So autism, one thing I always like to say, and I strongly believe, is that there's more similarities between autistic people and ADHDers than differences. So autistic people, we also differ in the way we experience our emotions, our senses. So we might have hypersensitive senses, or we might be undersensitive to certain things. We also differ in the way our attention manifests itself. So there's a lot of shared features and there's a lot of shared experiences, unfortunately, which come with that, such as being victimized or ostracized. So there's these shared elements of neurodivergence. But if I was to talk about the specific kind of diagnostic features of autism, what those are differences in the way someone communicates and interacts with other people socially. So both in terms of your verbal behaviour, the way you speak, and also your non-verbal behaviour, like the way you use eye contact, the way you use gesture and so forth. So the way this might look different across the spectrum is that you might have some people who have a co-occurring learning disability. So they might really not use spoken language. They might use alternative means of communication and behaviour to kind of convey what they need. Whereas you'll have some people who would have previously got the diagnosis of Asperger's syndrome, where their language is structurally normal, but it might just be a little bit pedantic, a little bit old-fashioned, like they're speaking a slightly different dialect, though you can still understand them. And a really key feature of autism when it comes to social interaction and communication is that we really struggle with what's called social imagination. So that's being able to understand what other people are thinking and feeling, and also to do that in a kind of applied future-telling way. So a way this often shows up in the workplace is I might not appreciate all the social ramifications of the things I do and the things I don't do. So I missed this meeting. I'm not necessarily aware that maybe if I skip the meeting, my boss will think, oh, Rachel's not actually, she's not interested in this thing. And my colleague might think, oh, I thought Rachel cared about this, but actually she doesn't. So everything we do and don't do has many social ramifications. And autistic people, we find it very hard to imagine all those social ripples going out from our actions. The other specific criteria for autism is what in the criteria is called repetitive and restricted behaviours and interests. Basically, what that means in plain language is that we like things to be the same. We like routine, we like predictability. I personally think one of the best things about being autistic, because there's a lot of difficulties, but one of the best things is that you can eat exactly the same thing every single day with no problems at all. So I hear some people saying, oh, I don't know what to cook for dinner today. And I'm just like, don't have to worry. It also means you have passions. So autistic people, like ADHDers, our focus, our attention tends to be very narrowly focused on things rather than doing everything. We tend to be very intensely interested in certain things, and then you have encyclopedic knowledge about those things. But I'd say in general, both autistic people and ADHDers, we show this pattern of we can't do anything half-heartedly. You either do the whole thing and you do it to 200%, or you don't do it. We tend to be very highly, highly conscientious, very strong sense of justice, right and wrong. So there's a lot of shared features and also a lot of shared experiences there.
Thank you. That was a really, really incredibly helpful overview, Dr. Rachel. And in terms of autism diagnosis, are there similar challenges to the ones that you outlined regarding the diagnosis of ADHD, particularly for people assigned female at birth?
Absolutely. So historically, like ADHD, autism was really only thought to occur in males. And that meant that people assigned female at birth were not diagnosed for a very long time. And because they weren't diagnosed, they didn't appear in the research, which informs all of our interventions, all of our clinical knowledge. So it means that actually for both of these things, a lot of what we think we know about them is based on people assigned male at birth. So you've got a very similar phenomenon where, again, autistic people assigned female at birth have to be more obviously different. They tend to be slightly better maskers, to have more normalized outward presentations.
And before we come on to some of the challenges that individuals with ADHD and autism face in the workplace or relationships, I'm just really curious, are you seeing any evidence of more investment in research in this area to help close that gender research gap?
There is more investment. I think a really helpful thing in the last couple of years, has been official recognition that that actually 1 to 2% of the UK population is undiagnosed autistic. And we think there's something similar there for ADHD, as in we have official recognition now that there are so many undiagnosed neurodivergent people. And if we look at who those people are, they tend to be older, they tend to be people assigned female at birth. So yes, there is development, and there is development in tools to detect these individuals, but it is quite slow.
And then apologies for asking a very obvious and naughty question, Dr. Rachel. But I know, say, from talking to some friends, they're in two minds about whether they want to know if they have ADHD or not. And I've observed this particularly with people I know going through the menopause transition. In your view, what are the benefits of getting a diagnosis?
I thought about this recently and I thought of two V's, vindication and validation. But there's other benefits as well. What I mean by that is if you are undiagnosed neurodivergent, you know you're different and everyone around you knows you're different, but you don't have an explanation for it. So you will tend to struggle in life and you will have no sort of justification for that. So you will say, it's my fault. Why can't I just get on with it? Why can't I do what everyone else can do? It's my fault I got abused or bullied. Whereas often when you get a diagnosis as an adult, you do not get any like material support. But what you do get is an explanation. It was never your fault. There's a logical, completely reasonable reason. You know, you're not a failed neurotypical. You are a perfect example of what an autistic person or an ADHDer is like. And it allows you to find community. You can't find community very easily when you think of yourself as broken or, you know, a failure. Whereas suddenly you realize you're a perfect example of an autistic person or an ADHD, and then you can find that community. So we tend to see a late life autism diagnosis is a very positive thing for people. Or even identification, because it's worth saying that many people cannot access a diagnosis in adulthood, but self-identifying also gives you some of those benefits.
And is there, and that's incredibly helpful, and I can see from some of the comments in the chat that's really helped people as well, Dr. Rachel. Is it helpful as well in terms of helping you understand the tools and resources that you can now access, or, you know, self-access even, to help you think about how you can manage situations or environments that you find more challenging?
Absolutely. It allows you to forgive yourself a bit for struggling, to not be so hard on yourself, to not push yourself into these situations, but it also allows you to find strategies. Exactly.
And I think one of the things we'll come to, because I know Dr. Clare wrote an article about ADHD, I'll post a link to that, but I know, Dr. Rachel, you've recommendations for resources and places that people can go to. If you wouldn't mind, when you have a moment, popping those into the chat or sending them to me, then we'll share them with everyone after this webinar as well, when we send out the link, because our whole purpose in doing these events and why we created My Menopause Centre with Clare's expertise in this area is to empower women with evidence-based information and advice so that they can thrive in all stages in their life. And that really is probably more than anything the purpose of this conversation this evening, to help people to live their best lives and be themselves. And I love how you've reframed this as you're the best version of who you are, and you know, you're calling out of the benefits of the diagnosis are so compelling, and I know that's really resonated with people on the webinar this evening. So before we open up and come back to Dr. Clare and yourself, just to talk about neurodiversity and menopause and the intersection of both, it would be really helpful if you could just call out, Dr. Rachel, what you have seen as the biggest challenges that individuals with ADHD or autism experience, in particular in the workplace or in relationships. This is a theme that's run through several of the questions, and in a moment we'll come to talking about strategies and things that you can do, and particularly as it relates to menopause as well. But again, based on your experience, what have you seen?
So that's such a great question. I think perhaps the biggest problem sort of encapsulates a lot of the other ones, and that is that we speak a slightly different language, but most people don't know it, and we may not know it as well. So what I mean by that is essentially because we struggle to understand what other people mean, you know, they say one thing, but they actually intend something else, or they have, you know, thoughts and feelings that we can't read. So this is true for autistic people and ADHDers. We struggle to read neurotypical people, and they struggle to read us. This is something that's been called double empathy theory. And what this means in relationships and in the workplace is that we often get things wrong. We misread people. They don't understand us correctly. It means that because we differ in the way we express our emotions, the way we communicate, the way we interact, we often stand out. We are often bullied. We're often exploited. If you can't understand the intentions of other people very well, it makes you very vulnerable. And if you're different, again, makes you very vulnerable. So we do see, unfortunately, lifelong high rates of victimization in neurodivergent people from school onwards, including in the workplace and including in relationships.
So I guess this also highlights the importance for employers to understand this so that they're alert and aware, because, you know, the benefits of creating an inclusive environment and a culture that supports real exclusivity, including and not just looking at gender, but really looking at neurodivergence as well, and real differences are really clear. The business case has been proven. I think sometimes it's just the lack of awareness that it's not in the agenda or it's not front of mind. So for those who are on the webinar this evening, or I'm sure when Dr. Clare and I speak to organizations, we can all play a role in raising awareness and raising the importance of just being aware and alert and providing people with the right training and tools as well. So Claire, if I can come back to you then, a really important topic on the intersection here of menopause and neurodiversity. And I know that this has come up with patients that you've seen in the clinic, and that's what prompted us to even start this conversation a few years ago. It was because of what we were saying. So you've already touched on how hormonal changes during menopause can impact us and impact neurodivergent individuals differently. Based on your experience, how have you seen the two interact, and what are the biggest challenges have you seen from the patients that you're treating and what you've seen in the research?
Yes, no, and Rachel and I have spoken about this also. So there's one of the big issues here is lack of evidence. So what I'm going to mainly talk about is what I see and hear anecdotally from experience. So neurodivergent people, whether ADHD or autistic, often have more extreme reaction or more significant reactions to changes of hormones. And so what you might hear is a story of really bad premenstrual symptoms. So really low mood for the week before a period, or heightened anxiety, poor sleep, but a more extreme version. And I haven't seen data on this, but premenstrual dysphoric disorder is the really extreme version of PMS, where women may even feel suicidal before a period. And and a lot of the symptoms, a lot of the stories you may hear are at that much more severe end of the spectrum. And so if we then go into the perimenopause, if you look at very mainstream data on perimenopause, you know, in the early perimenopause, one of the very early signs is premenstrual symptoms worsen. And it's because you get heightened changes in hormones. Everybody gets a change in hormone before a period by definition, because that gives you a period. But that becomes a more significant change in the early perimenopause. Your periods might not even have changed at this point. There are subtle changes in hormones, but because of how your brain just happens to be wired, you react more greatly, for want of a better word, more the symptoms are just more severe. And then when you then go into the perimenopause, and sometimes the lid just comes off, where for the first time women might feel anxious or struggle with low mood. If you're already struggling, or your brain is creating these more severe, significant reactions, then that just all worsens in the perimenopause. And I see that a lot. And it can be really distressing for women. And then the other side of that then we start talking about HRT, and often you need so many different ways of managing this. There is rarely one magic bullet. But because of sensitivity to hormones, there may be sensitivity then to the hormones in HRT. And I know there is emerging data that this is the case. And so particularly progesterone in the second half of our menstrual cycle, that's when we have progesterone and then it dips, and we need to give you progesterone in HRT as well. And so often as a doctor, I'm having to be really careful, or we're really gingerly being sort of looking at different ways of taking the progesterone, because often there's a more severe reaction or there's sensitivity to the progesterone. Eventually, I know there was a question, eventually symptoms of the menopause do get better. As Helen asked me earlier, how long do symptoms last? It is on average 8 years. And basically, I always think it's a bit like a snowstorm. You shake it in the perimenopause, all the little bits of plastic float up, and then they resettle. They do settle, but it might not be in quite the same position as before. So symptoms can settle after the menopause, but it may be that it's not quite the same as it was. So you may lose some symptoms, you may gain other symptoms. So my view is this can be a very challenging time, but it's good to talk about that challengingness, because that helps you get the right support. But you might need more support, I think, is a really good way of thinking about it. I don't know, Rachel, what do you think? Oh, you're on mute.
Yeah, I would second a lot that you said. What we see in the research area, it's really important to say, first of all, that people who've had a really boring menopause don't want to take part in research. So we tend to hear from people who've struggled. But what we see is that, really interestingly, being neurodivergent affects the way you experience menopause. So you might experience the kind of classic menopause symptoms as more severe, but going through menopause also affects the way you experience your neurodivergence. And this is really important, because this is something you won't find on descriptions menopause online. So the way that menopause affects neurodivergence, it kind of intensifies emotions that are already challenging. It intensifies difficulties with executive function, with planning, with thought. Sensory sensitivities can be amplified. And these are areas where neurodivergent people are already vulnerable. And one way you can really see the intersection of being neurodivergent at menopause, where you've already struggled with, say, cognitive changes your whole life. But what we've seen in a number of studies is that people find they previously had adaptive elements of their neurodivergence, job skills like hyperfocus. People find sometimes that these flip into disabling at menopause. And this can be devastating for people, because neurodivergent people tend to have very low self-worth. So we often pin our self-worth to productivity or a job. And suddenly at menopause, people can find they are robbed of their skills, in the words of one of our participants. So this means it's complicated, because we can't just think about menopause for neurodivergent people. We have to think about that interaction of menopause and neurodivergence. So our participants talk about autistic menopause as a thing, because it's not just menopause or just autism. It is the combination of those two things. And that's what isn't served in kind of in most kind of freely available content about menopause.
Yeah, and I would absolutely agree with you, Rachel. That's definitely what I'm seeing in many of my patients. You can't take one away from the other, and that's why management really has to be the whole person and the bigger picture and really holistic. And yeah, I completely agree. I think that's a really nice way of talking about it. And we haven't really touched on cognitive symptoms. When I was talking about the menopause earlier, I spoke about psychological symptoms, physical, vasomotor, but I think it's probably the cognitive symptoms, often the sort of brain, as well as all of those, but brain fog, loss of memory, loss of your usual coping strategies that mean that you've got through to this point, and then the brain fog and the poor concentration when you've been dealing with inattention, but you've got your strategies to cope. It's just the lid, as I say, patients tell me it feels like the lid has been blown off. Just to second what you've said. Yeah.
So I guess everything that you've just both said underscores the importance of having a diagnosis, because knowledge is empowering. And so in research that Dr. Clare and I had conducted, we commissioned some research a few years ago. And while this might seem a statement of the bleeding obvious, it really showed, the data really showed that the more prepared you are for the menopause, the better your experience of it will be. So in that spirit, we've spoken a lot about the challenges. You know, Claire and you, Dr. Rachel, have really called out the need to look at this in a holistic way. These things can't be separated. We are integrated human beings. We're not slices of symptoms. So if we know that we are neurodivergent, what can we do in advance? Is there anything we can do in advance of the perimenopause or the menopause transition to better prepare ourselves to avoid or to minimize the impact of symptoms? First part of the question. And second, because I suspect these will flow into each other, if we're in the middle of the storm and experiencing all these things where it can feel utterly overwhelming, what can we do? Where is the life raft? Where can we grab it from? And how can we help ourselves into a better place?
Is that to both of us, Helen?
It's to both of you. And I think a conversation between you both would be really helpful. Just on that, because look, we all know there isn't a silver bullet. It's going to be a whole range of different things.
Yeah. Okay, so I'll start, Rachel, and then because I really want to know what you're going to say, but from you know, sort of slightly more briefly from me, I just think preparation is power and all of that sort of thing. And I think if it's really difficult because you don't want to dread what's coming, you want to live your life. But I think if you can have your ducks in order or in a row or whatever the analogy is, and you know, if you know, I think if you know, my observation is that it can be really tricky to find support. And so if you know where to go for support when you start to feel a rumbling that something's not quite right, then it seems to me that would be helpful. So understanding what the symptoms are, understanding the impact of symptoms on your brain, understanding that those symptoms may be more pronounced, may have a greater impact, and then knowing in advance where to go for help. So when you're feeling terrible and stressed, etc., you've got a button to press. That is my observation. But Rachel, what would you say?
I would agree with much of that. People across our studies have said, you know, that menopause was much harder because they didn't know they were neurodivergent, because they had no idea what to expect. So we have written a book that's coming out later this year where we've spoken to 16 autistic people and really integrated their experiences throughout, as well as their advice, their guidance, their best tips, and self-education, being prepared was number one. So trying I think you're very impeded if you don't know you're neurodivergent because you can't find the right information. But if you do know, then try to indeed find out as much as you can beforehand. The things that people said as well were that try, as difficult as it is, self-compassion is so essential. So accept that it might be harder for you. There's very valid reasons for that. It's not your fault. Give yourself permission to struggle. Give yourself everything you need. Buy all the things you need. Cancel all the appointments you need to. And recognize that it won't last forever. And I can maybe refer to a question that was put in the chat earlier about what happens after menopause. So we don't have a lot of research on what happens for neurodivergent people post-menopause, but it seems that things do calm down. So in our book, people talking about the post-menopausal period, some people say, actually, I feel better than I ever have. And things have sort of gone tranquil. Other people say I'm still not functioning at quite where I was before menopause, but things have got a lot calmer. So I think for coping, it's really important to remember that the perimenopause will not last forever, and that there are things you can be helped, as Claire has alluded to as well. There are treatments, there are things that can be done.
That's so important, isn't it? This too will pass. Sometimes that can be the thing to hold on to. Claire, I'm going to come back to you on kind of symptom management and treatment, and then build out from there and other strategies. There have been quite a number of questions running through here about HRT and progesterone. It would be, I think, really helpful if you could give an overview of the role of HRT, its benefits, and you'll have seen the questions in here about progesterone intolerance, and any thoughts and recommendations that you have for people who believe they might be intolerant to progesterone. And I'm going to put some links. I'll go on mute and put some links into the chat about some brilliant articles that you've written on the topic of progesterone.
Yes, yeah. And there's a question just popped up on alternatives to HRT, Helen, and we could pop the link there as well. Yeah, so HRT is basically two hormones. The HRT is the mainstay is estrogen, and we are aiming to give just enough estrogen to manage symptoms at the menopause. We can never replicate the big ups and downs that we had before the menopause. We're literally just wanting to fill in those deep troughs. So estrogen is generally great. The estrogen bit is usually easy. The issue with estrogen is that it can thicken the womb lining and increase the risk of cancer of the womb lining if you don't take a progesterone alongside it. So you take the progesterone to basically keep your risk of cancer of the womb lining, cancer of the womb, to an absolute minimum. So this is why doctors get anxious, or there was a comment there, my doctor seems impatient. Absolutely. And it's really tricky as a doctor because you don't want to cause harm, you don't want to do harm, we want you to feel good, but we know that the progesterone bit of it can be challenging. So my top tips would be, again, it's just looking at all the different options. And I know Helen's brilliantly posting all the information on the thing, but it's knowing that there are basically limited options for taking progesterone. There's body identical progesterone. The drug name is Utrogestan or Geprotix. There's a combined patch containing a synthetic progestogen called northisterone. You could have a Mirena coil fit. There are other synthetic progestogens that you can take either mixed with oral estrogen or separately. And sometimes you have to go through a really painful process of trial and error, because unfortunately there's no test we can do that will tell us which one will suit you and which one won't. Often, but not always, the body identical Utrogestan Geprotix is tolerated better because it's the same as our progesterone. But then if you had bad PMS, bad PMDD, that's often related to the progesterone part of your cycle. So that's not a fail-safe theory. If you swallow progesterone, sometimes it impacts on your mood, but if you use it vaginally, off license, having discussed that with your doctor, often it's tolerated better because you absorb it into the blood vessels around the vagina. It doesn't pass through your stomach, so breakdown products are different. Many, many, many women, when I mention Mirena coil to, recoil in some way and think, no way. Absolutely, yeah. And Mirena can be a really good option because it's the minimal amount of progestogen into your whole system, while it sits, and it's the most effective way at keeping your womb lining thin. And for most women, you don't have a period. So everybody knows somebody who's got a horror story about a Mirena, but in reality, I think that they're really well tolerated. And if I fit a Mirena, for example, I always say, if you hate it, I will remove it if I'm in the building. You know, it takes literally 1 minute to remove. And in the last 15 years, probably 2 people have taken me up on that offer. So if you can have a Mirena fit, a Mirena coil that just fits into the womb cavity, it can be quite a good way. And then the other ways are just literally working through different options, and trying to find a regime that you can take that has sometimes you have to reduce the progesterone and accept that small risk of cancer of the womb lining, but actually it's the only way that you can balance the estrogen helping your mood and cognition and managing the womb lining need for progesterone. It's really tricky, and it's why sometimes speaking to a menopause specialist could be helpful. And it's challenging to challenge your GP, but if you're not getting anywhere with the GP, do ask for a referral, even if you have to wait. And, you know, don't be afraid to just lay it all out there. Just say what's going on for you. And we can usually find a way of something that you can tolerate looking at the risks. Rachel, would you add to that? I know you had to leave and come back, but we were talking about HRT and the challenges with progestogen, and it can be really difficult, can't it? But we usually find a way forward.
Yeah, I think one thing I would say is we've had people who've said it's an absolute lifesaver. I can't function without it. Autistic people and ADHDers. But in terms of autistic people, I think it's worth mentioning that we're often, well, both groups, we can be very highly anxious. But autistic people in particular, we really struggle with unpredictability. So I think a lot of people can feel very, very scared about trying something. So they need more support from their doctor to actually be able to try it.
Yes, I think I would absolutely second that. And that's why having the longer appointments, having a bit more time that you get with a specialist it can be, and having time to think about it. And it is really difficult, isn't it? Because it's it's unpredictable. And just having to accept that I can't say anything better than we're going to start a really low dose and we're just going to try it. And if it's awful, please stop it and be in contact. You know, I can see that it can be really challenging. But it
I'm
can
just
help.
going to.
Yeah. Oh, sorry, Helen, go on.
No, go ahead, Claire.
No, I was just about to say, there was a question also about medication for ADHD and HRT, and I have got plenty of patients on both, and it's fine. It doesn't interact. And the ADHD medication can be a godsend, the HRT can be a godsend, and both together. And then, you know, psychological therapies, which will be specific to you. This is not one size fits all, and different people will find different approaches. better or worse. I don't know. You're nodding, Rachel, but we talk a lot about CBT, cognitive behavioral therapy, in menopause, but I do understand that that's not often suitable for people with people who are neurodivergent, and often it's a more tailored psychological approach, but that can be so challenging to access, particularly through the NHS.
Yeah, I was just going to add to that. It's really tricky because we have no evidence base, as has been said earlier. So people that we've spoken to have talked about how important it is that psychological approaches are adapted. So to give you an example with CBT of how it might interact badly with neurodivergence, is that neurodivergent people are very often told and taught to feel like the way we see the world is wrong, is incorrect. And so CBT kind of comes from that viewpoint of, maladaptive thoughts cause my mental illness. But we know that autistic people and ADHDers, their reality is that they live in a world where they're marginalized. That's real. So actually, if you come with that unadaptive approach and you sort of say, challenge your thoughts are illogical, and you can actually compound, the real stigma, the real challenges that people live with. So third wave approaches such as DBT, dialectical behavior therapy, acceptance and commitment therapy, compassion focused therapy, these are more about changing the way you relate to your thoughts and your emotions. Not saying that, your thoughts are wrong, but they give you tools around coping with strong emotions, for instance. So there's some growing evidence base for those for neurodivergent people, but we don't know about neurodivergent people at menopause, unfortunately.
Brilliant. Thank you. I'm very glad you're back, Rachel. I was scouring screens for you. So thank you for letting us know. I've popped in some links to a whole range of different articles. Rachel has already included a link on where you can go to for tools. Unbelievably, the hour is almost up. I'm just going to, we will in our newsletter, we'll send out all of the links as well and put it on the website so that you have everything in one place. If I may, a few last questions, mastermind style to you both. If I could start with, there's been a theme running through several of the questions around challenges that are some people in the webinar tonight have experienced or are experiencing in the workplace. Based on your experience, what workplace accommodations, or as the parlance goes, reasonable adjustments, do you think might be helpful for people to request or ask for?
Do you want me to start with this, Claire?
Yes.
So it's very, very individual for everyone. But I think, again, we're in such a new intersection that presently we don't have autism and menopause, or ADHD and menopause reasonable adjustments. We have menopause adjustments, we have ADHD adjustments, we have autism adjustments. And my recommendation to employers is always to take a really flexible trial, case-by-case approach, borrow a bit from here, borrow a bit from there. So because the way you experience your neurodivergence changes at menopause, some of the adaptations that neurodivergent people need at work won't actually be ADHD and menopause adaptations. They might just be ADHD adaptations that the person hasn't needed previously. So you've got three intersections, and my advice is always to borrow from each of those. So look up what kind of adjustments are associated with menopause, ADHD and autism, and then pick and choose and trial them.
So we can definitely send out an overview of menopause related workplace adjustments. And I'm just wondering, Rachel, if you have any recommendations of where we could look to see where there are workplace-related ADHD adjustments. What do you think, Claire? We could send them out together so that people, because as you said at the top, Claire, every woman has her own unique experience of menopause and ADHD, so it's that holistic view, isn't it?
Oh, completely. And yes, and what will suit one won't suit another. And you know, everybody's experiences are completely valid. You cannot generalize at all. So no, I think that's a great idea.
Yeah, and Rachel, I see you popped it into the chat. Thank you. That's great. So folks, if you look out for our newsletter, we'll post this probably in next week or the week after, and we'll put it on our website as well with the video link and on our YouTube channel. Claire, a question I know you get a lot, very quickly, blood testing for estrogen levels.
Yeah, not very helpful. And somebody asked about the Dutch test as well, which is a urine test which has no evidence base behind it and we don't know how accurate it is or not. But no, estrogen levels, the issue is, really briefly, fluctuate significantly. You can feel terrible and have what looks like a normal for premenopausal estrogen level. So try not to go down the blood test rabbit warren, because it can be quite distressing seeing that your bloods are normal, but you might still be in the menopause transition, and postmenopausally the estrogen just won't be measurable. But at times in the perimenopause it might not be measurable also, but that's not predictive of the menopause. So you can hear it's tricky. And certainly a lot of the urine tests, the same applies. We don't know, although they say they're validated, they're not formally validated. We don't use them within the NHS, and anyway, the same would apply.
Thank you. And then we've had several questions around sleep and joint issues. So what I'm going to do is I'm going to, Claire has written some excellent articles in our symptom checker. And I'm going to, sorry, I didn't post the right link there. I'm just going to pop those into the chat as well. And while I'm doing that, I'll start with Rachel. Any parting thoughts or closing thoughts or messages for our audience or for the people who catch up with this video? Rachel.
Be kind to yourselves. It's a challenging time. I want to just quickly respond. I'm trying to type a message in the chat to someone who's saying that they're really anxious about trying HRT because of the various risks. I think this is a really challenging thing, and often it's about weighing up relative risk. So there's it's a very complex issue. But we take all kinds of medication which improve our quality of life and maybe protect our health, even though they introduce slight risks. Like, I will probably live the rest of my life on antidepressants. And there might be slight risks associated with that, but my quality of life and my risks would probably be much greater without them. So there's no one right answer. It is entirely 100% your decision. But I think if you can, I hope you can find someone to talk about it with and get that support.
Yes, and if I could just add, I think it really helps to look at the absolute numbers. I totally understand the risk of breast cancer and why women worry about it. But if you look at the data, over a 5-year period, it's 4 additional cases of breast cancer per 1,000 women, when 23 of us per 1,000 might get breast cancer anyway, just from being women. So look, I'm not belittling or diminishing that risk of breast cancer, but just talking it through, as Rachel said, and putting it in perspective, I think can be really helpful, because the headlines are scary. The absolute numbers don't make the headlines, and they're not scary. Yeah. Oh, Helen, I think you're on mute.
Oh my God, after 4 years, you'd
I
really
know,
think, wouldn't you?
Helen always says that I am usually the one.
I didn't want, I realized my clickety click of my typing might be a bit distracting. I tried to be very quiet. But as my husband told me, I have misophonia. But as we draw to a conclusion, Rachel, that was brilliant. Be kind to yourself. And thank you for picking up on that question. And, you know, really don't compromise your quality of life. Claire, any parting thoughts from you?
No, just speak to somebody. I think I agree with Rachel, be kind to yourself, but I think validating symptoms can be really helpful. Appreciating that this is not a personal failing, that these are chemical changes that your brain is going through on top of the diversity. And yeah, and it just get the right support, get the right help. And if your GP is not being helpful, then go to a different GP and just keep banging on a door and don't be afraid to ask for a referral. And yeah, just get the right support. I think that can be challenging in itself, but just keep going, have faith.
As a small thing, if you're neurodivergent, you may also benefit from taking an advocate with you.
Oh, yeah,
so
good idea.
have someone with you. They can take notes, they can remember things if you're overwhelmed, and if they know what you want to get out of it, they can help you make sure you get that out of it.
Yes. And don't be afraid to try and ask for a double appointment at your GP practice. You might not get one the first go, but don't be afraid to ask.
Excellent tips and advice. And I guess all I would say on top of it is do not suffer in silence. You're not alone. You're not going mad. You deserve the support. And to quote from that great brand L'Oreal, it's because you're worth it. So with that, I think a huge thank you to Dr. Rachel and Dr. Spencer. I know you've both had very busy days, but this has been, I think you've seen from all the questions and the reactions, such a helpful and enlightening conversation, and really appreciate you taking the time out this evening. And thank you to everyone for dialing in this evening and for all of the brilliant questions that you've asked, and for all of you opening up so much in the chat. As I said, the video will go up shortly in the Restless website. It'll go up on our website in My Menopause Centre over the next few days. It'll stay up on the Restless website for a week. It's permanently on ours and on our YouTube channel. And we'll collate all the links and pick up with Rachel. Dr. Clare and I will pick up with Dr. Rachel to look at doing an integrated view of workplace adjustments for menopause and ADHD. I think that will be a very good practical tool for everybody to have. So good night, everyone. Thank you so much and have a lovely evening.
Thank you.
Bye-bye.
Bye, everybody.
Bye-bye. Good night. Bye-bye.
Thank you, Rachel.
Thank you. Lovely seeing you, Rachel. Thank you. Lovely seeing you too, Claire. Bye-bye.